Good evening, ladies and gentlemen. Welcome to the Pitt County Board of Health meeting for August 2014. This time I'd like to call the meeting to order. First item, is there any public comments? If not, we'll move on. I don't think there is. Next item on the agenda is the minutes from the June meeting. I need a motion to approve the June 2014 meeting.
So moved.
Second.
I have a motion to approve and a second. Any further discussions or comments? If not, all in favor?
Aye.
Opposed? Motion passed on the minutes. Next item, physical report.
Mr. Chairman, board members, you have the July 31st financial report. That is the first month of fiscal year 2015. It's the first month's report's usually pretty boring, so this one's no exception. A couple things I will point out. Our revenue, the original budget adopted by the Board of Commissioners, our revenue and expenditures were $9,561,000. That's in the far left-hand column of your report. Since then, we've actually had two new grants. One is an environmental health grant, which I believe it's the Agency for Food and Drug Officials. It's about a $21,000 grant. And then we also got a grant, a smoking cessation grant from the state of about $61,000. So the budget's already increased about $83,000 from the time it got adopted to this report. The pro rata section of the budget really is just, since we're 1 month into the fiscal year, it's really 1/12 of the current budget. So you'll see the pro rata budget is $804,000 roughly. We brought in through the end of July $1,225,000. You bump that against the expenditures of $590,000, and we have a pretty healthy surplus at 1 month of $635,000. Of course, there's a lot of timing issues involved in that, and I'll just kind of go down the revenue portion of this kind of quickly. You'll see our Medicaid revenue, the pro rata budget is about $20,000. We brought in about $22,000 in the first month, so we're a little above budget on that. And you'll see a new line, Medicaid PM, and that is Medicaid per member per month. And I wanted to break this out separately from Medicaid because this is a little bit of a different funding stream. The regular Medicaid is what we earn in our clinics. This per member per month is the Carolina Network,
Community Care Network.
the Community Care Network of Eastern North Carolina gives us a wire transfer every month based on the number of Medicaid eligible folks in the county. That wire transfer is about $53,000 every month. And it's, we don't have to do anything as far as billing. It just automatically comes to the health department to fund two particular programs, pregnancy care management and care coordination for children. And 1 month, the pro rata budget would be $52,896. And you can see in the year-to-date column, we've actually brought that money in. However, a portion of that money we have not used to actually, we have not spent on those two programs. So you see in the timing column where I've backed out $4,400, what I'm really doing here is setting up a reserve for these two programs that we can spend that money at some point in time in the future for these two programs. So it comes in as revenue, but I've got to reserve a piece of it with the idea at the end of the year we're probably going to have about $45,000 in this reserve to fund these programs in the future. The Medicaid cost study, that is another Medicaid revenue stream. That is from our cost settlement. We normally get that very late in the fiscal year. So I've actually added the pro rata part to the timing column to kind of match our revenue and expenditures. If you go further down the line, you'll see clinic fees and environmental health fees. Both of those are slightly over budget as of July. DHHS, those are state funds that we are reimbursed in the following month for the prior month's expenditures. So you'll see we brought no DHHS funding in July because we won't get that funding until August. So I'm estimating that we'll get about $106,000 in August to support July expenditures. The county, at the beginning of every quarter, they transfer that full quarter's county appropriations. So the county's transferred 3 months of operational costs to us. I've backed out 2 in the timing column, make revenue and expenditures match. So when you get over to the year-to-date adjusted, that large surplus that we have dwindled away to about $65,000. That's about where we would expect to be at the end of July. I'll be glad to answer any other questions. Yes, ma'am.
The new line item with the Medicaid PM, can you explain that program? Is that more of they're paying us in advance for services rendered later per patient?
They're going to pay us that same amount. Well, it's been the same amount for the last year, but it is based on how many, it's so much for every Medicaid eligible person in Pitt County. So we're to take those funds and use it for child care coordination, pregnancy care management. However, we have not, through July, we have not used all that money to, in those 2 programs. So the amount we haven't used is really income we haven't yet earned. We can earn it in the future if our expenditures exceed the revenue coming in. And so, and I will probably earmark it to buy new PCs for those staff, some new equipment for them in the future.
It's not in lieu of payment for services?
No.
Let me clarify too, John, that it's actually Medicaid eligible people in that population served. So it's women within the childbearing age who would be eligible for pregnancy care management, and it's children less than 5, I believe, that are in the range for the care coordination for children program. So it's not all Medicaid eligible.
Right. Any other questions?
Any other comments? Or if so, I need a motion to approve the physical report.
So move.
Second.
I have a motion to approve in a second. Any further discussions, comments? All in favor?
Aye.
Opposed? Motion passed for the physical report. Next item on the agenda, 2013-2014 budget closeout.
Yes, sir.
Go ahead.
You have that report also. We have now closed out fiscal year 2014 with the exception of an auditor's review. And just go down the list of the revenue we have brought in is $9,195,000 versus expenditures of $8,997,000. So right now we're sitting with a surplus of $198,000. But that per member per month reserve that I spoke about for July, that all that reserve, that same theory applied to all of 2014. So our funders finally got a reserve schedule that we could understand and agree with. So what we've in the timing column where you see I backed out $59,000, that is the reserve for those programs we will have sitting on our books July 1, 2014 to fund future expenditures in that program. So that takes our surplus really down to $138,991, where we budgeted to use $308,823 of fund balance. Not only are we not going to have to use that, we're actually going to add to our fund balance the $138,991. So it's, you know, I think at previous meetings I said we were going to probably break even, not have to use fund balance. And then I went out on the limb and I said we might, you know, actually put $150,000 into fund balance. I was about $12,000 off. We're going to actually increase it by about $139,000. So that's where we are. The only caveat would be if our auditors find something that they want to make an adjustment for. And I don't know what that would be, now that we've reserved this per member per month fund. And I'll be glad to answer any other questions. That's a pretty good turnaround from what we had anticipated earlier in the year. And I will, you do have this slide, but I just wanted to kind of roll forward our fund balance. We started off fiscal year 2014 with $1,103,000 in our fund balance. We anticipated using $308,000. We actually are going to put about $139,000 in. So going into fiscal year 2015, we have $1,242,000 of fund balance. We've budgeted $371,000 to support fiscal year 2015 operations, and we're also estimating about $150,000 for an electronic medical record. That could go up or down. Probably won't go down. And we would use fund balance to support that, just going forward. So we're, quite frankly, we're in a better financial position coming out of the year than we were going into it. And I'll be glad to field any questions on that.
Any further comments about the closeout for 2013 through the 2014 budget? Thanks for the information and well done.
Thank you.
Next item on our agenda was the tobacco-free parks rule. We're going to put this on hold where Dr. Morrow has stated we're waiting on some feedback from some towns and municipalities. Is that correct?
Yeah, Mr. Chairman, if we could just talk about that a
Sure,
little bit.
we
I
can.
want to make sure our public understands what's going on as
Sure.
well. But we were hoping that we could bring to you tonight the rule for approval, but as usual, that some of these things have taken longer than expected. And Janice Gallagher, our county attorney, is here tonight to answer any questions y'all may have. We have gotten, just to remind folks, we sent out letters and resolutions to all the municipalities in the community, as well as a lot of agencies, and these are the ones that we've gotten back, and it's basically almost all the municipalities that we have that have supported having a public health rule. And again, just to remind the public, the advantage of this Board of Health rule is that the Board of Health rule covers all the parks, would cover all the parks within the county, whereas if we left it up to the municipalities, each individual municipality would have to pass an ordinance to get approved through their town council to do the same thing. So this is a lot simpler for the municipalities and cleaner, and it keeps things standardized across the county. The other thing is, I think that we had hoped through some grant funding that we would be able to actually purchase the signage for all the municipalities so that they would not incur any cost with this. Unfortunately, our community transformation grant funding was cut, as y'all are aware of. We talked about a couple of months ago. That grant is going away next month. It closes out the end of September. But there is hope that we can get a similar grant. The state is applying for a grant around chronic disease that we should know something about later in September or maybe October. And then also our county applied for what's called a pitch grant through the CDC, which also could possibly help us with this effort as well as other chronic disease issues in eastern North Carolina. The pitch grant would cover 8 of our current 9 counties that are in our region, and then the grant that the state is applying for would actually cover all 9. We wanted to cover all 9 with the pitch grant, but we ran up against a population cap of 500,000 people, and if we didn't get below that cap, we were going to be competing with big cities across the country for this grant. So we felt like our chances of getting being successful in terms of receiving the grant were much better if we got below that 500,000 cap. And so we asked for volunteers, and Wayne County was willing to step back and let the other 8 counties participate in that pitch grant application. So we'll keep our fingers crossed on that one too. Again, but we won't know that probably until late September. So we have to move ahead with closing out the community transformation grant. And John and some of the other staff, the Community Transformation Grant, Amy Haddam and her staff have been very actively working on trying to make sure that everything is in order when that grant closes out. So anyway, that leaves us with not sure about our funding for signage at this point to assist the parks folks with getting signage for the tobacco-free parks. But we do have support in these resolutions, and I mentioned the municipalities. We also have support from the Pitt County Medical Society, Pitt Partners for Health, just reading through some of these, East Carolina University, the Executive Council there, Teddy Bear Child Advocacy Center. So there are just a lot of folks in the county who have voiced their support for this. We want to make sure that I did want to mention Farmville recently took action on their resolution, and they, unlike the rest of the municipalities, had excluded electronic cigarettes. Now, there's a lot of discussion, as everybody knows, around electronic cigarettes. We need to thank our county commissioners, Dr. Johnson. Thank you and your fellow county commissioners who voted to support the changes in our county smoking policy to include electronic cigarettes last week. That was successful, and I think that really helped us at the health department because we were dealing with people coming in our lobby using these devices around pregnant women and children. And as we've talked about, we just don't know whether these devices are safe or not. And the FDA is taking action on that. But I think it's important that people get educated about these risks. The tobacco-free parks rule that we've drafted so far would include electronic cigarettes. But I think we should have more discussion with the questions that Farmville, the town council in Farmville had about electronic cigarettes to see if we can satisfy their questions on those issues. And then we also have yet to hear from the town of Bethel and Falkland. We're trying to get some response from on whether or not they support this. I would like to give Janice an opportunity, if she wants, to talk about some of the legalities of this. There are, I think you have a list of the counties in North Carolina that have done this and the way they've done this. And I want to get you a draft as soon as possible. Janice is helping me with the drafting on this, as well as other people. But as soon as we can, I gave you a draft, a very rough draft, a few months ago to look at. And we've made some significant changes to that since then. So I want to give you an updated draft as soon as possible. One of the things we want to do is actually list the parks that will be affected by this. And Janice, if maybe you want to discuss that and how you feel like this needs to look and where we take it from tonight moving forward.
Sure.
That would help.
Good afternoon. Thanks for having me. I have been working fairly closely with Dr. Morrow on this proposed rule, and I'll start by saying I'm completely satisfied that this board has the authority under at least two different sources of law to enact the rule as it will be proposed. So you have the authority to enact rules to assure the public health, and then you also have specific authority in the Act to Regulate Smoking in Public Places law in the North Carolina General Statute. So there is clear authority to move forward down this path. The draft or proposed rule starts from a model rule that Dr. Morrow has spent some time revising to tailor to fit more particularly to Pitt County, and he and I have worked on that together somewhat. And I'm satisfied that the updated drafts, as he has proposed and is continuing to update, will accomplish the purpose to prohibit smoking in public parks. I think there are essentially a couple of key elements that will allow this rule to be successful. Included in here is education. Also included in here is that education will lead to largely self-enforcement of this rule. The rule does contain a civil penalty for violation, but largely it will be successful as folks are educated, as signs are posted, and if people regulate their own behaviors as a result of the expectations that are made clear within this proposed rule. It will apply jurisdictionally, as Dr. Morrow said, countywide. So I would like to have the additional time to follow up from those jurisdictions that we haven't heard from, Bethel and Falkland, to reach out to be sure they are in agreement. And then in terms of process, in order to enact a rule, and the Board of Health has done this before, once the proposed rule is drafted, it will be shared with you all and then sent to each clerk within the jurisdiction, each municipal clerk, to stay in that clerk's office for inspection. And there would have to be a notice published in the newspaper for 10 days, advising folks that they have the opportunity to view this rule at their local clerk's office or at the local health department. And after that 10-day period, then it's open for this Board of Health to take action to approve that rule, and it will be effective when this board says it becomes effective. Could be immediately or at some point thereafter. So I'm comfortable with the authority to enact the rule, the content of the rule as it's being developed, and Dr. Morrow and I have talked again and confirmed the process to be sure we've dotted those I's and crossed those T's, and then it will come back to you after it has been published in the newspaper for that requisite period of time for your further discussion, consideration, and adoption. Available to answer any questions that you may have.
I think one of the things y'all may want to think about is when we bring the rule back, do you want to have a public forum? Do you want to have opportunity for comment at one meeting and then come back later after those public comments, or the timing of that? But we do want to make sure that we get input from all the municipalities that we can. We don't want this to be a burden on anybody. We're really looking to, we're doing this for health reasons. We want children to be safe. We're already getting complaints. I see Alice Keenan in our audience, and I know Alice has firsthand experience with some of the exposures that are happening in our parks. It's a safety issue for children. It's in terms of secondhand smoke. It's a safety issue in terms of cigarette litter that kids are picking up and putting in their mouths. It's a safety issue for other people that are being exposed to secondhand smoke that don't want to be. It's a work issue for those employees in those areas being both exposed to these secondhand smoke and chemicals from electronic cigarettes that we don't know are safe or not safe yet. And they're actually having to pick up all this litter too. So it's more than just it's more than health, really. It actually is. It's work for our staff to have to clean up these cigarette litter. But the main thing is really protecting children. We want it to be in areas where children, we want this to be enacted in places where we know children are playing. We want those to be healthy places. We have talked about, for instance, the municipal golf course in Greenville not being included in this. That I think that's not where children typically go out and play, and it's very spread out. So if golfers want to go out and smoke their cigars or cigarettes while they're golfing, I don't think we need to stop them. That's not what this is about. It's really about trying to protect children and employees who are exposed to some of these hazardous chemicals.
And the proposed rule as it's drafted is intended to be reasonable, not burdensome to any municipality in terms of signage costs, and consistent with the scientific evidence as it relates to secondhand smoke.
And we don't expect the police to come writing tickets and arresting people for this. This is much like our current restaurant and bars laws. We haven't had a problem with that, and these other communities that have done this across the country have not had this kind of a enforcement issue either. I mean, it really is enforced by the public, who tells people, please put your cigarette out. I don't want to inhale your smoke. So that's what we expect from it. Thank you.
Thank you. Okay, next item, some new business. Communicable Disease Annual Report.
Good evening,
Kimberly
Chairman
Hardy's
and
going
board
to do that
members.
for us.
Is that gonna come up?
Have you got your slides, Kimberly?
Do you know what, yeah. Do you know where it's stored?
In that folder?
Which folder?
The one that was just on the
State
desktop.
Animal Control.
Let me see, I'm not sure.
Did you put it on?
I didn't. It's on the hub.
Oh, it's on Pub, okay. This?
Yes. Okay.
Oh.
Good evening.
Good evening.
The good news I'll start with is that we haven't had any dramatic changes in communicable disease incidents in Pitt County, but we have had significant changes in the service delivery. So the focus of the presentation tonight will be basically on those two topics. Everyone here knows that Communicable Disease Program Authority is based on the North Carolina General Statute, Chapter 130A, Article 6. Our communicable disease program objectives are to control the transmission of communicable disease with appropriate prevention and treatment, detect cases of communicable disease in the community, and monitor the incidence of new communicable disease cases. Our health department provides these services pretty much Monday through Friday, in addition to having services available 24 hours, 7 days a week through our communicable disease reporting line. Our health department provides acute communicable disease control through our NC-EDS surveillance system. We also provide case and outbreak investigations, implementation of control measures, and enforcement of control measures, and post-exposure prophylaxis for communicable diseases. Within the communicable disease program specifically, a lot of our activity is spent on dealing with diseases such as hepatitis B, hepatitis C, foodborne and vector-borne diseases. For 2013, January through December, this slide shows you that the majority of our cases of communicable diseases are related to foodborne illnesses, which is not a change in the trend that we've experienced for the last at least 5 years. This slide is very busy, and I'm going to kind of slide you to death, but you're kind of used to that by now. But just to kind of give you a visual in terms of where we've been and where we are currently with the varying diseases that I'm going to show you. So for 2013, there hasn't been a significant change with hepatitis B. Hepatitis C has been pretty stable. The case counts have not changed greatly. And Campylobacter, pretty much the same. And Salmonella. And Shigella. The takeaway point for those particular diseases are make sure you wash your hands and cook your food properly. The tick-borne diseases that our region has had to deal with include Rocky Mountain spotted fever, Lyme disease, and ehrlichiosis. As you see here in this slide for Rocky Mountain spotted fever, our case counts have not changed significantly. The suspects have, where they've decreased a great deal. Lyme disease, we've had actually 6 cases, which is an increase from 2012. And then ehrlichiosis, we've had 2 cases, 2 suspects. One of our programs that has experienced changes in regards to funding is our immunization program. Our health department currently provides immunizations at no cost to children who are eligible for the Vaccine for Children program. However, currently, with the changes in the state funding, we are not able to provide immunizations to children who have health insurance. We don't have an ability to purchase the vaccines with that right now, so it's just kind of a community information moment there. Immunizations for adults, we do provide those for adults, but this year, again, due to funding changes with the vaccine supply, we do vaccines for adults. The cost for the vaccines may vary, and again, if some clients have health insurance, we may not be able to provide those services at no cost upfront. Post-exposure prophylaxis therapy or immunization for rabies, we still do provide that for our community, and that is a pay upfront service. Our immunization program goal it has remained the same from last year to this year, and that's to reduce the spread of vaccine-preventable childhood diseases by ensuring individuals are age-appropriately immunized and to make sure that we manage outbreaks of vaccine-preventable diseases. The goal, one of the goals for our program is to make sure that 89% of all eligible 2-year-old children served by our local health department have documentation of age-appropriate immunizations in our North Carolina immunization registry. Currently, our health department's rate is 91%, so we are meeting that benchmark. Again, I said this last year, that we do collaborate with our community partners to help ensure that this rate remains high. Our other goal, or next objective, is to make sure that at least 76% of all eligible 2-year-old children residing in Pitt County will have documentation of age-appropriate immunizations in our North Carolina Immunization Registry. Right now, our overall county's rate is 73%. So that basically means that our community providers are partnering with us to make sure that those immunizations are entered in their selected practices, whether private or public in our county. So we still have work to do in this area. By 2020, we need to increase the age-appropriate immunization levels of all eligible 2-year-old children served by the health department to 89% or more. And our goal for this is to make sure we maintain our level or reach a higher standard. And by the year 2020, assure that at least 95% of North Carolina children ages 0 to 18 years old are represented in the North Carolina Immunization Registry. We have made sure that we have met the goal for all eligible 2-year-old children residing in Pitt County. So we've met that in 2013 again. So the other communicable disease service that we offer is STD examination and treatment. So the health department, on a bigger scale this year, provides confidential STD exams, testing, treatment, counseling, and referral at no cost. That has not changed. And I mentioned before that we have 24 hours, 7 days a week, communicable disease response and reporting information for healthcare providers. Our objective for our program is to monitor STD rates and trends in Pitt County, ensure adequate treatment is given to all patients that are seen in Pitt County by private and public medical providers. We do that through our NCED system. And also, we are charged to report incidents to the state's communicable disease branch and to the CDC using the NCED system, and to make sure we do that in a timely fashion. So this slide that you see here gives you an overall count of cases for chlamydia, gonorrhea, and NGU over the last, well, for 2013, and then 2007, as you see here. So it looks like we have experienced a decline in chlamydia since 2011, a decline in gonorrhea, and also a decline in non-gonococcal urethritis. This information was asked of me last year, and I was not able to give it to you, so I want to make sure that I report that this year in terms of the racial breakdown for disease incidents. Across the globe, for those 3 diseases I just mentioned, African-American population makes up a large portion, roughly 80% or so of the population that has those diseases. I didn't share this with you last year, but I thought it was important to share, and that is looking at how Pitt County compares to other counties across the state. You kind of have to turn sideways to look at these numbers, but the thing that I want to point out to you is that to your far right, you have North Carolina's gonorrhea and chlamydia rate at the very end. You have Pitt County kind of in the middle. And if you can kind of take a look at that, you see that we're only outnumbered by Edgecombe County for chlamydia rates. We have actually the second highest chlamydia rate in the state. That's important to me because when you look at Guilford and Wake, and Cumberland, and more so Guilford and Wake, when you look at those communities having more college age population, we actually have a higher number, and we've kind of held this slot for a while. Now, this is just for sheer purpose of showing trending. Our chlamydia rates since 2011, again, I did mention on the previous slide that we have experienced a decrease in the number of chlamydia infections, but from 2012, 2013, we didn't really see a significant difference. Same thing with gonorrhea for 2013. 2011, pretty good difference. This particular slide here, again, they're kind of busy, but it basically shows us that our female clients are the ones that are being diagnosed with infection more so than the male. Now, for our HIV services, our health department provides HIV positive counseling, follow-up, and referral to our community partners. We also provide investigation of disease control measure violators, and we also provide HIV syphilis partner notification services. As you can see here on this slide, this is a slide depicting our Pitt County incidence of HIV. Since last year, we've had just a few more cases, but trending over since 2009, it's remained pretty stable, except for some dips in 2010, 2012. For AIDS, you can see that we've been pretty stable with those cases as well. For syphilis, last year was a bad year. When I showed you this slide last year, I actually was showing you data from January to, it was a partial year bit of data that I showed you last year, and we've got those numbers in, so I thought I'd plug them in for you to see those. This time we had a significant increase in syphilis last year, and we're back pretty much to where we've been with 21 cases last year. TB surveillance, or TB disease, Pitt County Public Health Department does provide treatment, surveillance, and contact and case investigation for this particular condition. We provide direct and observed therapy, treatment of contacts, and isolation and other control measures for TB. We actually provide this service as mandated by the state at no cost to a patient. The goal of this program is to eliminate tuberculosis disease as a public health threat. Obviously, we're trying to reduce the number of new cases of TB and control the spread of tuberculosis in the general population. Latent TB infection, we actually had 53 cases last year of this condition. We had a very good continuation in terms of therapy for this population. Currently, we have 3 different treatment regimens, and it was actually the addition of the 12 weeks of directly observed therapy that's responsible for the completion. You see that 83% of our population who was treated for LTBI completed their therapy. And that's directly attributable to that shortened therapy regimen. I mentioned this last year, but we have had a decline in TB disease. Since 1980, we had about a 5% decrease per year in North Carolina. In 2013, we had 3 cases of TB, and in 2012, we had 5. This is some busy data. I'm just basically the summary of all this is that our TB nurse is doing an excellent job of managing TB and investigating cases and making sure we contact the contacts of the TB, the person of interest rather, to make sure that everybody initiates and completes therapy. Now, for our focus for where we were last year, I heard you all when you asked me those tough questions last year regarding what were we doing about our STD rates. That seems to be biggest disease burden that we have in relation to communicable diseases. So in 2014, we did something about it. Our focus last year was to improve access to care. In October last year, we started a walk-in clinic on Wednesdays, Walk-in Wednesday, for select clinic services to improve access for immunizations, STD, contraception, a variety of different services that we have in our health department. In August this year, on August 1st, we implemented a second walk-in clinic day. And obviously, the first one had to be successful for us to go back and actually add a second day. In September, and I'll actually go to that slide in just a minute that depicts the Walk-in Wednesday data. In September, we will complete our PIXI grant that we've had that has allowed us to implement express testing and community collaboration. This is just a slide to give you an overall picture of our attendance for our walk-in clinics over the last several months since we implemented it. And this is actually, you don't have a frame of reference for this, but this is awesome for us. It has increased our clinic attendance greatly. The next slide just gives you an idea that basically just says implementing a walk-in clinic was a safe gesture to implement. From October through April, you don't see a significant dip in services, and actually for the month of January you do, but we had inclement weather that took out 2 of our screening days. This just gives you an idea in terms of age group. That question was asked again last year, and I just wanted to give you an idea that 48% of our population that's taking advantage of the walk-in clinic is age 15 to 24. And again, that's more data regarding gender. So our takeaway for our program, communicable disease, if I had to say we've done anything the last year, we have certainly provided easy access to our quality healthcare services that we provide at the health department. We've improved our access in terms of making sure that it's timely. Patients can be seen within 1 day of disease recognition, which is very important when we're talking about controlling communicable diseases. Our next initiatives involve improving community awareness and education regarding existing and potential health threats in relation to communicable disease. Our PIXI grant is actually responsible for allowing us to do that. We have 3 events scheduled, or planned rather, for the coming months to have community partners to come in with us and help us address this issue on the community level. You have any questions? It's a lot of information.
I know that Mr. Reed had commented in his fiscal report about the positive financial news, and so seeing the numbers with the walk-in clinic, I was just wanting to ask you and him a question. I mean, obviously you're seeing more patients. Does that translate into a healthier bottom line? I mean, it's great for the health care of the patient. We want to do that, but does that impact the bottom line, Mr. Reed, or not?
Most of those services we do for communicable disease there is no funding for that other than some state funding we get. There's a little bit, but bottom line, no.
Bottom line,
But long term, if you're looking at preventive health care,
saving money,
you're saving money in the long run.
right?
Yeah.
But we're probably utilizing our staff better.
Yes, we are.
Okay.
We are.
Thank you.
And as I would say, as insurance expands, for instance, as more people come on to Medicaid or other insurance, and as Kimberly mentioned, we're trying to get to where we can bill all the insurance agencies for services. We can bill those insurance agencies for those services. That's been a change. It used to be that STD screenings were free to everybody, and insurance never even got involved. But nowadays, it's changed to where if people have insurance, you can charge those insurance companies. And the Affordable Care Act, a lot of what that did was it required insurance agencies or insurance businesses to pay for these things, that a lot of the things that public health was doing, like screenings and STD treatments and contraceptives, all those things. There is more and more reimbursement for it, but we've got a ways to go in terms of improving our bottom line, as you say, in terms of, but I think we're doing a much better job of identifying patients early on with communicable diseases, particularly STDs, and getting them treated before those diseases are spread. And that certainly pays off in the long run.
Any further comments or discussions? Thanks, Kimberly. Thanks for the report. Next item on, I need a motion for this. My crack staff told me I needed a motion for this.
Move to approve?
I need a second.
Second.
If there's no further discussion, all in favor of this annual report, say aye.
Aye.
Opposed? The annual report's passed. Next item on the agenda is the legislative update.
It's me, Mr. Chairman. Thank you. Yeah, I'll keep this pretty short. As everyone knows, the General Assembly is almost adjourned. I don't think they're officially adjourned yet, but they're getting very close. Overall, I think we had some really big concerns going in early with the legislature, particularly with the Senate's version, some of the changes that they had planned. But I think overall we fared much better than we thought we might. And I'll just report on a couple of things. We did lose about $400,000 in aid to county for our local food and lodging programs. That equates to $4,000 for Pitt County. But those are funds that went to our food and lodging program for inspecting restaurants. So that's gone. Also, the vector control program. This was mostly pretty small grants that went out to our county vector control, as well as many of the municipalities in our county received funds that was used to typically purchase mosquito spraying chemicals, larvicides, adulticides, and equipment to spray those chemicals with. So the vector control program was terminated. That's going to put some stress on communities in terms of coming up with funds to help control mosquitoes. There was the biggest concern I'd have to say is there are cuts in contracts and administrative expenses for the Department of Health and Human Services, and more than half of those contracts in the big Department of Health and Human Services, that's the largest department in state government, more than half of those contracts are in the Division of Public Health. So they're taking a very large cut, the Division of Public Health in Raleigh is, and they're going to have to find where in those contracts they can make those cuts. So we are going to have to stand by to see how that impacts us locally on the local level. But that's the biggest concern we have about what happened this year in the legislature. Of course, Medicaid reform did not take place, but their plan is to come back in November and act on that. So we'll be watching that also as that moves forward. Yes, ma'am.
Question about the food and lodging cut.
Yes.
I know that we will continue to inspect restaurants.
Oh, absolutely.
How will we compensate for that loss in state revenue?
Yeah, it's $4,000, and it was given to us for getting 100% of our restaurant inspections done. So some counties did not receive that. It was sort of an incentive. The money's being shifted to help improve the electronic system in Raleigh that keeps track of all the restaurant inspections. Mm-hmm. So I think we're going to be okay with that. It was sort of a bonus money that we would get when we hit that 100%, and we usually used it to purchase equipment and things. But thankfully, like John had mentioned, the AFDO grant that we just got was $21,600. So we can use those grant funds to do some of the same things that also was in our food and lodging division. So we've more than made up for that, at least this year, with those grant funds.
Thank you.
Any further discussion or comments? If not, I think you want to give us a little report.
Yes, sir, Mr. Chairman. Just a couple of things I want to touch on. Everyone, I guess, has read a lot and heard a lot through the media about Ebola. We had a conference call yesterday with the state in reference to Ebola. Let me rephrase that. There are no cases of Ebola in North Carolina. However, there are 5 people in Mecklenburg County that have been quarantined who returned from Africa. They work for a mission group out of Mecklenburg County or the Charlotte area. And so because of their risk of having contact with Ebola patients, they've been quarantined for 21 days. There are 2 other people that were treated for Ebola who arrived in Atlanta last week and are being treated there, and from what I hear are still improving. But I do want people to understand what the risks are. Ebola is not in North Carolina. The chances of transmission, I would say, are not very high. It is in particularly 4 countries in Africa, Guinea, Liberia, Sierra Leone, and Nigeria. There have been about 1,780 cases with 961 deaths so far, which is a mortality rate of around 55%, which is very high, but that's in Africa without, ready treatment facilities, without public health systems like we have here in the United States. So I'm sure the mortality rate in a country like the United States would be lower. However, there are no treatments. There are no specific antiviral therapies. There are no vaccines against Ebola yet. Those things are being worked on. It is transmitted from person to person. The good thing, though, is that it's transmitted, people are sick before they can transmit the disease. So, and the more sick they are, the more likely it is that they can transmit it. So it's transmitted through bodily fluids, and it's transmitted from person to person or from object to person. So if someone's sick, has bodily fluids on something and touches something, and someone else comes behind them and touches that, that's how they could potentially infect themselves. So most of these cases that are being seen in Africa and among the mission workers who have been exposed are due to breaches in personal protective equipment. So folks that did not have adequate gloves or goggles or masks or gowns came into contact with. So what's going on right now is, and this was the conference call that we had yesterday with the state public health staff, folks who are returning from these countries are being assessed. If they have had contact with a known or suspected Ebola case, if they've worked in the healthcare setting in the affected region, or if they participated in funeral rites in the affected region, then public health staff are screening these people to find out what their risk is, and if necessary, they're instituting quarantine measures. And that's precisely what happened in Charlotte the other day, where 5 of these people have been put into quarantine. I would say that we are still changing and revising recommendations. I just got these new recommendations last night from the state that had been updated from last week, and I'm sure we'll probably see some more changes in these things as we go forward. But the basic message, I think, to our public today is that the risk is low. I don't think this is something that people need to be scared of here in Pitt County. There are things in place to protect us from infections, not just Ebola, but any type of infection similar to this. thank goodness that we have a good public health system to look after things like this. But if physicians or providers have patients, identify patients that they even suspect could have Ebola, they've traveled to those regions and maybe they have a fever, then they're being urged to contact local public health departments. We've given them telephone numbers both for local and for state, 24 hours, 7 days a week that they can call and get support for evaluating these patients in terms of laboratory testing and in terms of assessing what the risks are and implementing quarantine if necessary, or isolation if the patients are actually infected. So that's Ebola. A couple other things I did want to mention. We are seeing, again, increases in pertussis here in the United States. That's whooping cough. We've had many cases here in North Carolina. California has had 760 new cases in 2 weeks. They've had thousands of cases. Almost 7,000 cases have been reported just in 2014. This is a completely vaccine-preventable disease, but we're seeing children who are not vaccinated that are getting pertussis, also measles for the same reason, and we're seeing adults who are carrying pertussis because they haven't been revaccinated or boosted. So it's important for folks to remember to check their vaccine status. And the last thing I wanted to bring up was influenza. We're just entering the flu season again for this year. The flu vaccine for 2014-15 season is starting to become available. The vaccine is going to protect against either three or four strains. There is a quadrivalent vaccine again available this year that has 2 A's and 2 B strains in it. But the strains are the H1N1 virus that we've been seeing since about 2009, and H3N2 type A Texas virus, and a type B Massachusetts virus is the third antigen or virus or antigen particle that will be in the routine vaccine. The quadrivalent vaccine will also contain the type B Brisbane strain of virus. But people have asked me, someone asked me today, what's our flu season going to look like this year? There's absolutely no way to predict that. We're just now getting data on what 2012, how effective the vaccine was at preventing flu in 2012. So it takes a lot of work to get that information. Bottom line is get a flu vaccine and get a flu vaccine every year if you want to protect yourself and your loved ones. So it's not just for you, it's also for those people that you come around. But as vaccine becomes available, it's not too early to start it. If you're going to your physician's office here in August, September, and they've got the vaccine in place, go ahead and start. Get the vaccine. There's no problem with getting the vaccine too early. There is a problem with getting the vaccine too late. So you don't want it to be more than, say, a year. Particularly elderly or infirmed need to make sure that those vaccines are kept up to date. And that's all I have, Mr. Chairman.
Yep. Quick question. if I
Sure.
might. Does California have a vaccination problem?
Yes. The question was, does California have a vaccination problem? Yes, they have children that are not being vaccinated, and every state has that problem. I would say, California is much more populated than our state, so they have a bigger problem. I don't know if their percentage of parents who refuse vaccination is higher. The California vaccine law, I'd have to go back and look, but I think they have a philosophical exemption, which North Carolina does not have. Some of the states in the country do have that, and I think this speaks volumes to why you shouldn't have a philosophical exemption, because the main thing, though, is that parents just haven't experienced, these diseases that are preventable, and they often put it off and don't do it. There's a lot of misinformation on the internet about vaccine safety still, unfortunately. The best advice I give anybody, I think, as a physician is, I've got 4 children myself, and I vaccinate all of them. If I didn't believe in it, I certainly wouldn't do it to my own children, and I feel very strongly that, you know, that if you love your children and care about them, vaccination is a great thing to do for them.
Are these cases that California haven't, are they being brought in from other countries, or is it strictly
Great
the
question.
kids that haven't been vaccinated or exposed?
No, it's actually, it's 2 things. It's children that haven't been vaccinated, and it's adults whose vaccine status has waned. The vaccine, you know, we used to think it lasted a lifetime, and it doesn't. It actually, your immune status wanes after so many years. So we're recommending that adults get pertussis added to their tetanus booster now, and we've been doing that for a few years now. And the other thing is children, newborns who do not have protection are getting it before they can be vaccinated, because they don't get vaccinated until they're at the earliest 2 months old. So some of these newborns, unfortunately, are coming into contact from adults, and those are the ones that we really worry about, because small children with pertussis can die, whereas most adults, you know, they get sick and they have a bad cough, but they generally don't die from pertussis like small children can. So those are the biggest concerns, and because of that, in California, they're urging pregnant women to get vaccinated in their 3rd trimester, so that immunity will be passed on to their baby, at least protecting them for a short period until they can start receiving the vaccine.
Thank you, Dr. Moore. Any further questions or other comments? If not, I need a motion to adjourn.
So moved.
Second.
All in favor?
Aye.
Thank you. Good night.